Hi, everyone. It is now 12:01, so we will officially begin starting the webinar. Andrea, if you would like to go ahead and introduce Casey, it is all up to you guys.
Okay, great. Thank you, Laura. Hi, my name is Andrea Yevchuk-Spillner, and I am Vice Chair of the Mentor Network Committee for the National Hartford Center of Gerontological Nursing Excellence. We welcome you to the Leadership Webinar Series. Before we begin, I want to provide some details about how to obtain the 1-hour continuing nursing education credit. To successfully complete this program and be awarded the 1 contact hour, you must register for the webinar with an email address, attend at least 50 minutes of the seminar, and complete the online evaluation. A potential conflict of interest occurs when an individual has the opportunity to affect educational content about healthcare products or services of a commercial interest with which he or she has a financial relationship. There are no conflicts of interest to disclose for this program. Today, we are pleased to have Dr. Casey Shillam join us to present on Influence, the Understated Power Play in Academic Nursing. Before she begins, let me share a bit about her with you. Casey Shillam, PhD RN, is a gerontological nurse, associate professor, and associate dean of baccalaureate education at the University of Portland School of Nursing in Portland, Oregon. Dr. Shillam has extensive experience in curriculum development and in launching new programs. Prior to joining the University of Portland, she was the founding nursing program director at Western Washington University, in collaboration with local community college, hospital, and public health partners from around the Northwest region of Washington State. She has served as an expert nurse consultant to the AARP Center to Champion Nursing and America's Future of Nursing Campaign for Action, and has developed a variety of programs supporting nurses in their leadership development. Recognized for her strong leadership history, Dr. Shillam was selected for the final cohort of the Robert Wood Johnson Foundation Executive Nurse Fellows Program and completed the fellowship in September of this year. We are happy to have her share her knowledge and expertise with us. Dr. Shillam, I'll let you continue. Thank you very much.
Wonderful. Thank you, Andrea. So first, I just want to confirm that everyone can hear me. So Laura or Andrea, can you confirm that you are able to hear me?
I can hear you, yes.
Okay, wonderful. Thank you so much. So I am thrilled to be able to offer this webinar today. I have a long history with NHCG&E and have had the benefit of receiving a lot of support from the National Hartford Centers throughout my master's and doctoral education, and then I've also been able to continue that relationship on through my work in academic arenas. And so I was very honored to be asked to present my work to you. And this work really has come from a place of when I entered into my Robert Wood Johnson Foundation Fellowship, I recognized that there's a lot of work that happens in leadership as an actual science and an area of scholarship. What I didn't recognize was how many places there are intersections between leadership and other concepts that can truly impact one's ability to be a leader. And so through the 3-year fellowship, I have developed a new understanding for the role that influence does play in the world of leadership, in the world of our academic arena. And so I'm happy to be able to share this work with you today. I am going to just briefly describe what my goals are for my time with you today, and that is that I am hoping that I will be able to describe some of the emerging data that describes the importance of influence as this key leadership competency for nurses, to define some strategies for how to look at your own influence capacity and what that can do for advancing through academic ranks, whether your focus is in a teaching-intensive environment, whether that's in a research-intensive environment. It really is looking at how are we developing influence capacity to advance your career. And then finally, I'm going to share my own scholarship work in how influence has impacted that work for me, and then provide some questions, some key questions for you to start thinking about how to increase your own influence capacity in your work. You'll notice that we do have an area for questions and answers that you can type in a question at any time. So please feel free to use that as the method of asking questions as we go through the presentation, and then I will have some time at the end where we can also entertain some more of a dialogue between everyone. So the first thing to start with is understanding that connection between influence and leadership. As those of you who are members of NHCG&E, you know that there are a lot of ways that leadership is supported, leadership development. There are opportunities for the annual Leadership Development Conference in conjunction with the Gerontological Society of America meeting. And all of these are ways that NHCG&E has supported and sponsored leadership development. And it's just one of many national movements that we have for improving leadership capacity in nursing. But yet, despite all of this work on advancing leadership, we still see that leaders are not necessarily viewed as to be likely to influence healthcare redesign, according to a Gallup poll that took place in 2010. That is the Gallup poll that helped with the launch of the Future of Nursing report from the Institute of Medicine. And we also have now recognized that the influence of nurse leaders needs to happen in order to be able to improve healthcare quality and safety. So while we need nurses to be influential in these environments, we still see that they may not have that influence capacity. So with the launch of the Future of Nursing campaign, we know that the IOM report really calling for nurses to become leaders, to use influence in transforming healthcare redesign has been a very strong focus of our profession. And so that has to take place in all arenas, not just the healthcare industry, but most importantly in academic settings. And so what we know is that we have a number of tools that can help with measuring influence, that can help with looking at one's own style of influence. There are a lot of instruments that are out there that can help us with defining what is influence capacity. And so I'm going to be talking a little bit about those. As I mentioned, when I went into my Robert Wood Johnson Foundation Fellowship 3 years ago, I was really struck by this idea that I was wondering, how did we get to this point where the most trusted profession in the healthcare arena, nurses comprise the largest number of healthcare workers, over 3 million nurses compared to all other disciplines in the healthcare arena, and we consistently come out in polls annually as the most trusted profession. So I was really struck by wondering, how can we, as the most trusted profession, not be seen as having influence? And so that has taken a turn for me in my own professional development and in my own work with understanding leadership as this key core competency. How do we make sure that we're embedding influence as a very strong component of that leadership development? So in order for us to really be able to have a comprehensive understanding of this discussion and all be on the same page, I think it's important that we talk about what are the definitions of leadership and what are the definitions of influence that I am working from. In this work, I have learned that there are a wide variety of definitions of these words, and it's easy to just say that nurses need to be leaders without really understanding what does that mean to everyone, to different areas of nursing, whether that's academic nursing, policy nursing, healthcare leadership nursing, or if that is in interprofessional arenas. So there are a lot of definitions of leadership. It can be the action of leading a group or an organization. It can be the definition of leadership could be placed on a person who's guiding, or the power or the ability to lead people. We also see that there are some business definitions of leadership that I am pulling from for my own definition, that leadership is the ability to see a problem and be the solution, that it can be behaviors that bring the future to the present, that are these really almost visionary transformational kind of definitions. And then this last one, I really do kind of appreciate that leadership is the ability to unapologetically express and see out your business vision. So these definitions of leadership have influenced my personal definition of leadership. And then taking it more to the healthcare definitions that I've seen and have explored and studied, it can be this is the important part where we distinguish healthcare leadership in the work that we do as academics, because recognizing that in a lot of places, leadership can have a definition about being a specific governing body if you look at it in terms of what the Joint Commission defines as leadership. So the Joint Commission sees leadership as this very tight, narrow definition of those executive officers or senior managers who are known as the C-suite, so those high-level executive leaders of an organization. We also can see the Center for Creative Leadership, National Health Services, can think of it in terms of empowerment of frontline clinicians in decision-making capacity to create direction, commitment, and alignment. And then Angela McBride, of course, is one of our great nursing leaders that I really appreciate her perspective on healthcare leadership. And she states that becoming a leader is not just a matter of becoming skilled or knowledgeable, but using one's skills and knowledge in order to make a difference. And so I share this with you because this is important to set the foundation for how we talk about influence. And giving you my operational definition of leadership for this talk is that leadership to me is a process by which an individual uses a set of skills and attributes that are associated with the ability to affect change at all levels within an organization so that we can all work towards a commonly defined goal to advance health. That's what we do in schools of nursing when we are preparing our future nursing workforce. That's what we do in research endeavors when we are exploring how do we help improve patients and populations with our research. And then we transition that work then into what happens in nursing practice for those who go into practice and for those populations who are the beneficiaries of the work that we do in research. So then going back to this connection again between leadership and influence. One of the things that we do have a strong body of evidence in influence research is understanding that there are different influence styles. And these are important to recognize in your own leadership capacity for knowing how do you interact with others, whether that's with your peer group, how do you interact with students, how do you interact with supervisors or those who are in leadership positions in your organization. Also recognizing how you influence those outside of your organization, but that are really important for you to advance your work, whether that is in your scholarship of teaching or in your scholarship of research. So just brief definitions of these different influence styles are important for recognizing that it isn't that one necessarily only uses one of these styles at all times, but that we oftentimes have areas of strength where we're really gifted in one influence style, but knowing that there may be times that we have to use the other influence styles depending on our goal. So rationalizing as an influence style is when you put forth your ideas and you offer logical, rational reasons to try to convince others of your point of view. So trying to help others really come to this rational understanding of course this is what you would want to see because it makes sense. Asserting is more of an influence style in which you insist that your ideas are heard and considered, and you really challenge the ideas of others. So this could be seen as more of a confrontational type of an influence style. And again, while it isn't necessarily the best approach for all situations, there may be times when you have to use an asserting style of influence in order to move an agenda forward. Negotiating is kind of the middle ground on these influence styles. So in a negotiating style of influence, you look for compromises and you try to make concessions so that you can reach outcomes to satisfy the greater interest. And then when you look at the inspiring level of influence, this is where you try to advocate your position and encourage others with a sense of a shared mission. So really getting people to be excited about possibilities and trying to get them to all become really much more inspired about that vision. And then the final influence style that we see is that bridging style. So in bridging, you build relationships and you connect with others through listening, through understanding, through building coalitions. And so it really is more of a community organizing type of approach to influence. So there are different types of ways of evaluating your influence style. In my work of understanding my influence style, I have found that I am very strong in the negotiating style. And then not negotiating. my weakest area is in negotiating. My strongest areas are in inspiring and bridging. And so what that's helped me do is understand that there are times when I need to be able to use negotiating in order to influence, so I have to focus my effort there much more purposefully because it doesn't come as naturally to me in my everyday leadership work. The next thing I want to introduce to you is this really wonderful model that helps understand and explain the value of influence in knowing how to use influence as a very specific tool in your work in your academic environment. So influence is, in this Adams influence model, is defined as the ability of an individual to sway or persuade another person or group based on these very specific characteristics. And so the Adams influence model follows these groups of authority, communication traits, knowledge-based competence, status, and time and timing. And the way that you look at this model is really looking at it as a camera shutter. That's what this visual is depicting, is a camera shutter. So in the inside, you see influence is the goal, and that there are target perceptions and there are agent perceptions. I'll talk to you a little bit more about what those mean in a moment. But you can see that there's a target of influence up on the top, and then down below an influence agent. And that typically would be you in this case that we're talking about now. So we're talking about you as an influence agent, and you're trying to influence something, and that is your target. And what the different areas are around are the same for the target of influence as for the influence agent. So those same 5 target areas of authority, communication, knowledge, status, and time and timing. And what you do is in the context of those outside influences of social systems, interpersonal systems, or personal systems, those can change and adjust, and that then leads the influence agent to have to determine what kind of target influence should we be looking at or using in order to influence the target. So I'll explain a little bit more in just a moment here. Let's go through those actual 5 factors and the attributes. So in order to really understand your own influence capacity and to have influence, again, in your organization, in your research, with your students, with outside agencies, understanding that influence happens through these 5 factors. So authority is being able to recognize that you have access to resources, that you are accountable, that you are responsible for outcomes. Communication traits, looking at the ability to have confidence, emotional involvement in the work that you're doing, that you're able to effectively articulate your messages, that you have persistence, that there is a physical appeal of self, that you have a physical appeal of the environment. So looking at how you interact and communicate via the way you show up, whether that is in your work environment, whether that's out in a research site, or at a professional organization. And all of those things then lead to presence and how you're communicating your presence. The knowledge-based competence, this is really important when we talk about who we are as experts in our academic environment. As a researcher, as an academic, as a professor, you have to be able to not just have a knowledge-based competence, but be able to communicate that knowledge-based competence out. So knowing that there's all the different types of knowledge that we see in the different ways of knowing in nursing, aesthetic, empirical, ethical, personal, socio-political. These all reflect how we define ourselves as a profession and how we take ownership of our body of knowledge and really present ourselves as experts in that body of knowledge. The next is understanding status, and this is both the hierarchical position of where you may formally lie in an organization, but also the informal positions of status. So how you may be respected and revered in a research circle might be different than the actual hierarchical position that you have in your academic institution. So just recognizing where you do have status and always being aware of the key supportive relationships you need to advance your work and the reputation that you present, the reputation of your organization, the reputation of your research. And then the last is one of the most important and yet poorly understood factors of influence, and that is the importance of time and timing. And so knowing that you need to be aware of your School of Nursing's strategic plan, your university's strategic plan, so that when you're going in for an ask of support, you need to make sure that it's at a time when it isn't in conflict with the strategic plan of the organization. Knowing when to deliver your message and how to deliver it to different audiences is really important. So this time and timing is a critical step in recognizing that you can have more influence if you are aware of when and how you are delivering those messages. So overarching operational definitions now that we've gone through these descriptions of leadership and influence. So influence really is that ability to persuade or convince others. Leadership influence is persuading or convincing to affect changes or behaviors and actions that move toward common organizational goals, whether that's within your School of Nursing, in your university, in a professional organization. It really is moving toward a common goal. So phrasing and capturing the work that you do, whether that is in your teaching, whether that is in your research or professional service, capturing the way in which that leads towards the organizational goals is critically important here. And then academic leadership influence is building on that leadership influence to impact workplace performance, to impact the way your team of colleagues in your school or your colleagues on your research team are motivated to do the work that you want to do, to advance your own research agenda, and really to improve that perception of collaboration. In this work that I did with the Robert Wood Johnson Foundation Executive Nurse Fellows Program, I had the honor of being able to work with Dr. Adams, so the one who created the Adams Influence Model, and our team was able to evaluate the needs for how can we help best support nurses in developing influence. And we've actually developed an instrument that is in press right now and will be coming out in publication shortly. And what this is aimed to do is really to help nurses identify in your own organization and in the context of where you work with your own agenda, with your own goals, with your own professional development plan, how can you assess those different areas of influence and identify ways to build the capacity in each of those areas. So I just wanted to put out that there are new tools coming out all of the time. There are new tools emerging almost every month right now, because we do recognize that in order for nurses to be able to develop that level of influence, we have to be able to support that in leadership development. So I'm going to give you just a brief overview of my agenda and my scholarship trajectory here. I included that component about my work at Western Washington University in my introduction of my brief bio because it's important to understand that that's the context of this work that I'm presenting. While I'm at the University of Portland now, this work all started when I was at Western Washington University in a small rural community in Northwest Washington State. And I do continue on this work with the Palliative Care Institute that was established there. And it's important to recognize just a little bit of context in order to understand this story that I'm going to share with you. So when I arrived to start a nursing program in this area, there were no baccalaureate or higher programs north of Seattle, Washington, which is only about 2/3 up the state, geographically north in the state. So basically the upper third component of the state of Washington did not have access to baccalaureate education. And there was a very large community movement and interest in improving palliative care. So this fit really well with my own expertise in gerontological nursing, in chronic care management and case management for older adults with serious illness. And so we founded a Palliative Care Institute. And here you can see that our logo or our tagline is, this is a place where we can heal without a cure. And so we all came together from the university, from the health system, a number of nonprofit organizations in the community. The Whatcom Alliance for Health Advancement is one of those. And then a bunch of different, a wide variety of community members. We had a group of hospice volunteers. We had a group of faith community leaders. We had faith community nurses. We had a group of musicians who had a very strong connection in the community, and they cared about advancing through serious illness in the community in such a way that they wanted to look at improving and becoming a community of excellence in palliative and end-of-life care. So we came together, and over the course of about 6 months, we developed what we called this blueprint. And this is just a graphic to show the 4 key areas of where we felt we needed to focus in becoming a palliative community of excellence. We had this first pillar of activating the community. The second was that we needed to have trained provider competency. We needed nurses, physicians, social workers, therapists to all understand palliative care in the context of the full trajectory of serious illness. And so that's really where I took the lead in that competency and training piece as the director of a nursing program. The third area was increasing capacity for advanced care planning and advanced directives. And then the last was developing a way where we could have outpatient community-based services for palliative care. And then across the bottom you can see that, of course, financial sustainability was important for this work. So in each element of this blueprint, influence was a critical factor. And so it helped that as I was in the midst of this work in the community and in my scholarship and research, that I was also doing this work in the Robert Wood Johnson Foundation Executive Nurse Fellows Program. And so I was able to really purposefully bring in influence as a driver for all of the work that we needed to do. And so what I'm going to do is just go through and briefly describe some of the ways that influence affected our ability to be successful in all 4 of these endeavors. So when you look at the activated community, this was a wonderful, very community-driven work group that understood that the community or the consumer has to be as actively involved in shifting and changing what happens in healthcare as the healthcare system itself. That we cannot simply depend on the academic environment and the research pool that states something is important to do, like improving access to palliative care, that the health system cannot necessarily just figure out how to offer those services, but that the community, the voice of the consumer, those who will receive the care, they need to be the ones who drive the care. And so what we were able to do was host some community forums where we just held little roundtable discussions and identified what were the community priorities. We held workshops on implementing the Respecting Choices model for advanced care planning in the community. We were able to develop this very robust program called the National Healthcare Decisions Day Ramp-Up events. And so National Healthcare Decisions Day happens on April 16th, and that's a day of awareness for the need for advanced care planning. Happens on April 16th because the originator for this movement stated that it should be the day after taxes because the only two things we can depend on in this world are taxes and dying. So it was just kind of a little bit of a comical way, but it really does capture people's attention for knowing that we have to be prepared for what we're doing with our advanced care directives. So hosting this event with National Healthcare Decisions Day as a ramp-up a month before that, so on March 16th every year, we host these really large community organization workshops for people to know what it means to get your advanced care plan in order. And then the goal is that by that April 16th National Healthcare Decisions Day time, that we have a certain percentage of the community who've actually filed their advanced care directives with their provider, and then those get put into the system with the healthcare system. We had a number of newspaper articles that were written and published, and then we had this really incredible back of the bus campaign that occurred. So you can see here we had actual billboards developed, and we had these signs that went on the public transportation buses in the community, and this one says, "Dying happens." And then underneath, "and we should talk about it." And then it had a website there where people could go and actually learn about these workshops. So we were able to approach and touch over 1,200 participants in the first 2 years of these workshops. We have no idea how many people were affected by the newspaper articles and the other events that happened in very informal ways. And we had 120 attendees in those in that very first ramp-up event that we hosted. So you can see that the ways that we actually influenced community members was in bringing them together in a way that wasn't just talking about advanced directives. It wasn't talking just about end-of-life care, but it had some kind of a draw to bring people into the fold where they could connect with one another on a human level. So knowing that if we're going to get community members activated, we have to be able to influence them to see a draw for why they want to even become a part of this movement. Why should they care about giving their time to come to these events? So you can see on this picture here, one of the things that we did is that every single event that we host, we have a graphic designer, a graphic artist, come, and instead of taking boring minutes that get typed up and then sent out to everyone, we actually take this graphic representation of the work that we do, and then these pictures then get framed, and then they follow us along to every community event that we host. And so this is just one example of how we influence community members to want to come to an event. They know that there's going to be an artistic component. They know there's going to be a musical component. We connected in with that group of musicians, and they hosted different kinds of music at every single event. There were times when we had dancers come and perform dances that had been developed specifically around care of people with Parkinson's or care of people through the dementia process. And so having those kind of artistic components did influence the involvement of the community and became a very active and involved community. So the second area that I wanted to touch on is the second pillar of trained provider competency. And when we think about how to influence healthcare providers, everybody is influenced by the option of being able to attain continuing education units. So we recognized that we had to not just build something where we would get providers' interest, but that they would truly have a benefit from coming and they could see the value of giving their time in order to advance this agenda. So we were able to host, we've hosted now 3 summer institutes that comprise of either 2 or sometimes 3-day conferences, bringing in world-renowned leaders. We brought in Rochelle Bernacki, who works with Atul Gawande on the serious illness checklist, and had her actually do training for both providers and community members, patients, families, on what this serious illness checklist does. So we also knew that we needed to bring in alternative therapies. So bringing in our complementary and alternative providers from the community was also very important for getting that buy-in and having the ability for them to influence others. Another thing that we did was we partnered up with ELNEC. I specifically worked on the revision of the AACN Peaceful Death document to what we now have as the CARES document. That then also led to ELNEC creating these online modules for undergraduate nursing education. And so what we've done is we've partnered with ELNEC to be able to offer those modules in a variety of ways so that they don't necessarily just have to be used for pre-licensure nursing students, but they also can be used in a variety of places that care of older adults happens. So we're using it to set the framework for how we support continuing education in skilled nursing, long-term care, residential care facilities. So recognizing, again, that level of influence that needs to happen, we pulled in things like accreditation standards. We pulled in the expectations and requirements for continuing education. And knowing that that is how we influence the provider to become involved was a very effective approach. Next, understanding the adequate capacity for advanced care planning. Here again, we knew that we had a different audience that we had to participate in, and this is where we looked at the legislative component and the policy arena. So the Whatcom Alliance for Health Advancement was the nonprofit organization that was very influential in developing this blueprint. And the work we did through WAHA in adopting the Respecting Choices model is that we also recognized there was a wonderful opportunity to work with the state of Washington, because the state was also working on an initiative to improve advanced care planning and documentation of advanced directives. So this goes back to that time and timing component of influence I was talking about. We recognized the opportunity. The state already had this on its legislative agenda, and we were able to pull in the experts from the Whatcom Alliance for Health Advancement to influence the state's decision to move forward with adoption of this Respecting Choices model. So it was a wonderful way that we linked in the work of our local community and influenced actual legislation at the state level. Another example of influence that occurred in this arena was that we knew we needed to have a way to document and capture that we were making advances with filing of these advanced care directives. And so when we recognized that it would be very helpful to have some kind of way of tracking what community members did to document their advanced directives with their primary care providers, it was really difficult to think about how we were going to measure that as an outcome. But we recognized that we had only one health system in the community, and perhaps that was a more effective way for us to track and measure the outcome of filing an advanced directive. So we took it to the nurses who were working in our coalition. They then worked to influence the health system, and they were very successful in actually producing the ability to have a separate tab developed in their electronic health record system that specifically looked at advanced directives and showed the documentation that a patient coming in had an advanced directive. And then they further influenced participation of these ramp-up events with the health system and the training that needed to happen so that all of the providers in the health system knew that that tab was there, knew how to look for it, and knew what it meant, and were able to interpret the findings of those advanced directives. The final element is that of the community-based palliative care service. So the community was very vocal in wanting to have some kind of service that could be available in the community itself, not necessarily waiting for those who were very seriously ill, and in that transition really from palliative care to hospice, being in the acute care setting and then having a palliative care service offered via the hospital, but really wanted to push it out back into the community in such a way that at the time of diagnosis of a serious illness, patients and families would be informed about what the trajectory of palliative care services looks like, and then creating a space for that to happen in our community. And so, again, with this collaboration and a lot of different levels of influence to different community organizations, different providers, different researchers, and different ways that we connected together, we were able to identify a space where we could offer outpatient palliative care services. We were able to actually hire a care coordinator into that service, or into that space, into that work, who worked with a set of the primary care providers in the community and was a liaison between them and the health system. We also offered a space for different social services to have information, to have booths, to have actual people in that space where they were able to share what services were available. We were able to bring in integrative health providers and offer a space for community members, for patients, for families to come in and receive acupuncture, receive massage therapy. And then this last point I have up here about card making, this is another way that we were able to engage community members in the art of this work together. Again, going back to how do you influence community members to want to be a part of this work? How do you influence care providers and health systems to want to be a part of this work? This card-making event was an incredible way of bringing people together. So we recognized in one of our very first community organizing meetings that people were talking about the frustration they have with knowing that a friend or a family member was diagnosed with a serious illness, but could not necessarily be cured from it, but that they were in for a long haul. And we started talking about community and society expectations about what that means, and somebody piped up and said, yeah, you're not going to find a Hallmark card that says, wow, you're dying, and open it up and it says, that sucks. And everyone said, yeah, you're right. We're not going to find a Hallmark card that says that. But what if we could make a card that says that? What if we could make cards for one another that say a variety of things that may not be mainstream, but really get to the heart of who we are as a community? And so a group of community members and nurses worked on gathering supplies so that at every single event, we have a card-making station. They partnered with one of the stamp companies in the community, and they created stamps that had our Heal Without Cure logo on them, and they created stamps and materials that really did reflect what it is that we wanted as a community. And at every event, the card-making station was in place. People can go and come and make cards as they see fit. They can take a card, leave a card, and at this community-based site, those cards are available. People can, again, take a card, leave a card, do something to be able to continue that work that happens around how we heal and work as a community that happen maybe outside of medicine. So again, you can see in this story of my own program of scholarship here that there are so many ways that influence showed up in how I, as the influence agent, had to sometimes use authority to be able to get my message across to my target of influence. Sometimes it was really focusing on those communication traits. Sometimes it was focusing on that knowledge base. So when I specifically was developing those continuing education opportunities for providers, I did have to focus on developing and creating the message that went out that that we have a team of experts in palliative care. Here's the organized system that we're going to use for developing these conferences, these institutes, these continuing education opportunities. Using status, knowing who in this work was happening in the community, who did we need to tap because that person had more status in an influential capacity with a group versus those who may have had more status in formal roles. Knowing when to bring in the chief nursing officer of the health system or the chief executive officer of the health system. Knowing when we needed to tap the director, the medical director of hospice, or knowing when we needed to tap into the faith community leaders and bring in a pastor who had a really good relationship with community members to get that work done. And then again, that time and timing you can see in the example of the legislation that was being put forward, knowing what's happening in those policy arenas, knowing what's happening in your own organization so that you know when to present those opportunities for collaboration. So what I'm going to leave you with in this formal presentation part before we get into an opportunity for us to have a time for questions and answers are these questions for you to take this work forward into your work in your academic environment. And so the first question that is really important for you to figure out in terms of not just your academic trajectory, but looking at your program of scholarship, your program of how are you becoming an expert teacher, how are you in terms of being an expert clinician, how do you define your agenda? And by that agenda, I mean that overarching agenda for where you want to go with your academic career. You can then take that overarching agenda for your long-term academic career goals, and then you can break it into what are your teaching agenda goals, what are your research agenda goals, what are the service agenda goals that you have in terms of advancing the work of a professional organization that you're involved with. But really having that agenda figured out so that you know where to start focusing your leadership and your influence efforts. The next is to figure out that if you are the influence agent in that agenda, who is the target of influence? Who do you need to be specifically thinking about as the target of who you want to influence? And it can sound almost manipulative in a way if you think about, oh, I am going to go and influence my dean. and it shouldn't be done in a way that is disingenuous. But really, when you're thinking purposefully about being a leader in your academic career, you have to be purposeful and thoughtful about who are you engaging with in these relationship building capacities. So if you do want to advance your research agenda within your School of Nursing, who are the key targets of influence? Are you needing to develop a better relationship with your Associate Dean for Research? Are you needing to develop different relationships with other researchers at your institution, whether they're within the School of Nursing or outside of the School of Nursing? So being purposeful about knowing who is the target of influence will help you get to that level of influence much more quickly. The next question to ask yourself, of those 5 influence factors, which is your weakest? So you will have different times in different settings where you have different levels of influence. But if you look overall at who you are as an academic leader, where do you typically find that you are weakest? Is it in your level of authority? If it is, then you can purposefully set out to start attaining more leadership opportunities in your School of Nursing. So maybe it is that you start to put yourself in for being considered for being the chair of a committee, whether it's an internal School of Nursing committee, or if you see that you now are ready to advance to a university level committee, that you're putting yourself in there where you can start to attain more of that authority component. If you're fine in the authority and you're fine in the knowledge and you're really skilled in that communication area, perhaps it's status. Maybe you are not being viewed as the expert that you really are because of the lack of a formal designation in status. So how could you start to work with those leaders in your work to be able to advance you into those different positions of formal leadership to attain that status? Or if it's status within a community that you're trying to do work with. If your program of research is community-based and you are out in these communities and you're not seeing it advance the way that you want to, well, perhaps it's because you don't have a level of status in that community. And then that time and timing is so important, again, for understanding your ability to be influential in when and how you're delivering your messages of influence. So take a look at where do you fall in terms of the weakest and how might you be able to start building up your capacity in that area. Then look at what is the strongest and the most likely to launch your ability to really effectively exert influence. So if you really know that you are valued and appreciated and renowned for your knowledge base because of your program of research, then that's where you focus your effort for advancing your ability to build up that area where you might be weakest. And then this last question is, what is your plan to build influence capacity into your academic goals? So not only do you have to set an agenda and identify where are you perhaps not as strong in an influence factor, where are you the strongest in your influence factors, but then how are you going to build in that influence capacity into your long-term goals, whether that is in, again, your teaching goal, your goal as a researcher, your goal as a community organizer or as a clinician, that having that purposeful placement of influence in the leadership trajectory that you are in will help you to advance much more quickly. It will help you to attain your goals in improving the health and the health care of those that we're taking care of. It will help in improving the ability of the students coming through your program to really see what does it mean to be a leader in healthcare today. And I leave you with this wonderful quote that I just love, that the key to successful leadership today is influence. It is not authority. And so I challenge you to think about, where can you exert influence in your leadership? How can you advance the agendas that you have to improve health and healthcare? And to not wait until you feel that you have a formal leadership position that affords you authority, but that you really do embrace this opportunity that you have now, wherever you are in your career trajectory, to fully embrace influence, to fully support your leadership development, and to get you where you need to be so that our healthcare system can get where it needs to be. So that is the conclusion of my formal presentation here. We do have about 5 minutes. I would love to have some questions.
The conference has been muted. The conference has been unmuted.
And to see where we might be able to answer questions and think about what next steps we could take with this work. So I will remind you that we do have the Q&A under the participant feedback area, and that's where you can type in questions that you may have. Laura, I'm not sure if people are able to be unmuted in a way where they could ask their question on the phone if they would choose to do that.
The conference has been unmuted, so anybody who would like to ask a question has the ability to do so.
Wonderful. So Suzanne Schnell, I see that you have your hand raised, and so you are welcome to either chime in on the phone or you can type your question in if you would like. So perhaps Suzanne did not intend to raise her hand on the webinar. Does anyone else have any questions they would like to put forward? So talk about the bridging influence styles is Suzanne's question. I am really happy to talk about that. So if you look at the influence style model, and this question goes back to that, the model of different ways in which we influence. So that was rationalizing, asserting, negotiating, inspiring, and bridging. So the bridging method of influence is really focused on creating relationships and focusing on collaboration or building coalitions. And that is where you are identifying how your goals fit with the goals of others and bring them together. So it's having the ability or the capacity to really pull people together toward your point of view, but helping them all see that their points of view are also leading to the same ultimate goal. So you become, you have outcomes of building coalitions and communities. You can have the ability to really target in and identify like-minded people so that you can establish trust. And then bridging also means that you have an appreciation for hearing what other people's interests are and what their issues are. So having that ability to have a bridging style of influence means that you're a really skilled listener, collaborator, and that you can bridge different pieces of work that are happening in order to get people to all come together to move toward a common goal. And Suzanne, you are very welcome. She just said thanks. So Claudia, I see that you have your hand raised on the webinar. Did you have a question?
I don't have a question. I just want to say thank you that was a fabulous presentation, Casey. And I really like your focus on influence, not authority. Because I think it is relationship building, it is listening, but it's also making sure that we are proactive and at the table and being a part of identifying societal needs, but also a part of the solution. And I think it's very important that as we bring nursing to the table, that we really we get credit. But we also, we're not doing it for credit, but oftentimes nursing will do something and, oh, you know, it's okay. I don't need to be recognized or anything, but I do think that it really will help move nursing forward as we go forward.
Thank you, Claudia. I agree completely. I think that the reason that I'm so drawn to that Adams influence model, and I'm just going to back it up here, so we're looking at that while I'm providing my response here. The thing that I love so much about this model is that it indicates to anyone who needs influence that you have to be well-versed in each of these areas. And so when we look at the fact that, you know, as a profession, we are looked to be leaders. We are looked to change and advance health and healthcare. We are trusted by the public. And now we need to add in a very focused effort on influence so that we are seen as the influencing factor in all of those areas of advancing health. And so that means, yes, we have to have authority. We have to be skilled in communication. We know our knowledge base. I think that's where we have our strength as nurses, is we know our knowledge base. But recognizing that status is important and that we do need to be recognized for the status we have, and where we want to go with that is a critical component. So thank you for your comments, Claudia. And I see that we are at 10 o'clock. So Laura, are we ready to wrap up our webinar?
Yes, ma'am.
All right. Well, thank you everyone for giving your time today. I'm really excited that I had a chance to share this time and this passion that I have with you, and I wish you all the best of luck. Thank you.
And as a reminder, can I just ask everyone to please complete your program evaluation to receive your continuing education credit?